in where you can try and decipher those bits of information to try and work out when it is the right time.
Yeah, absolutely. There's always nuances, whether that's upper limb, lower limb or spinal. So I think it's just being really confident with your clinical reasoning and having a patient-centred discussion about options and how you move forwards.
Awesome. What a good way to start. Okay, so what have we got for you tonight? So the plan is we're going to go through upper limb stuff, including acute rotator cuff tears. So within that, we're primarily looking for signs that your patient may well have a rotator cuff tear, and then when and why you should refer on. Rotator cuff related shoulder pain. Previously, we used to call this subacromial impingement or subacromial pain, or perhaps even rotator cuff tendinopathy, so we'll talk about that. And we'll talk about shoulder instability as well. So that's going to be really important too. Then moving on to the lower limb, we're going to talk about acute knee injury. So I'm going to use my experience when I was working in A&E, and these patients with knee injuries would come into A&E, and I'd be able to work through that. So I'll give you some ideas there. And then we'll talk about patients who have an ACL injury or perhaps even a meniscal injury, and we'll be talking about when they perhaps, you know that they've got an ACL injury, you know they've got a meniscal injury, and they're under your care for rehab, and perhaps things aren't going so well. When should you refer back? So that's the thing we're going to talk about there. All right, so let's get cracking. First thing that's really important for us to say is that whilst Marie and I will of course give you all the experience and information and clinical reasoning that we possibly can, it's super important to say that things might vary a little bit depending on which country you're practicing in, which hospital you're practicing in, whether you're practicing in the National Health Service for your country or whether you're operating in the private sector, whether you're in a hospital that has an A&E, doesn't have an A&E. All these things come into account. So please always familiarize yourself and check against what your local guidance and what your local policy says, as that will ultimately dictate exactly what you do. However, as I said, Marie and I will guide you through everything that we possibly can when it comes to these kind of injuries. So let's get started with acute rotator cuff tears. So first of all, Marie, I'll come to you, of course, on this as a shoulder specialist yourself. So when we think about who we're referring on and what kind of patient, who are the main clientele, the main demographics of individuals who you might suspect have an acute rotator cuff tear in the first place?
So your age group wise, you're looking predominantly at kind of 40 to 75 with a real clear mechanism of injury, notably a trauma. Obviously, we're talking more about the acute rotator cuff tears this evening rather than the degenerative, gradually grumbling over time, no particular trauma group. So typically that's between 40 and 75. You can have some people that are slightly younger than that if they've had quite a big trauma, so bear that in mind as well, but that's roughly kind of the age group you're looking at. And when we talk about traumas, we're talking about a relatively sizable trauma, so something like a shoulder dislocation, for example, or falling down the stairs whilst holding onto the banister, that kind of thing. So it's not just I was hanging the washing out or I slipped into a door. We're normally talking much bigger than that for the younger patients. Obviously, as we get older, our tendons become a little bit more friable and a little bit more susceptible to tearing, particularly the rotator cuff. So as we get more towards that kind of 75 age range, it might take less trauma for them to have a big acute cuff tear.
Great, yeah, that totally makes sense. And I suppose is part of the reasoning there that as we get older, you mentioned the word degenerative there, our tendons are a bit more degenerative and therefore perhaps a bit more vulnerable when we have a trauma compared to, say, if we were to have exactly the same trauma at age 18 or 19.
Exactly. So think grey hairs and wrinkles on the inside. Your tendons will change as you get older. They become less elastic and a bit more rigid. So something more minor like falling over, banging into the wardrobe, or the bus stopping, jolting your shoulder, whilst that wouldn't necessarily cause a problem in someone 30, 40 years old, in a 75-year-old, that may be enough to cause them to have an acute cuff tear.
Super, that totally makes sense. So Is it an isolated rotator cuff tear? Actually, there are going to be occasions where people have more than one tendon tear, isn't it?
Yeah, absolutely. So the most common tendon to tear is supraspinatus, so your kind of superior cuff. But as we get older, the prevalence of bigger, massive cuff tears, so more than one tendon involved, more than kind of 5 centimeters, becomes higher. So that could be talking 3 or 4 tendons or 2, depending on kind of the trauma and the patient's general health and well-being. And I know you've also got here, Khalid, thinking about other things that could be presenting similar to acute cuff tears. So when we talk about the younger end, it is also worth bearing in mind whether they might have a fracture. So sometimes I've definitely seen patients in kind of their 30s where they've had a big trauma that present like they've got a big cuff tear but actually have a proximal humeral fracture, like a greater tuberosity fracture, and that's why they're presenting quite similarly. So it's worth bearing that in mind as well.
Sure, fantastic. And I'm sure you've probably had this in your experience as well, Marie, where, as you said, let's say we've got a 70, 75-year-old individual. They fall over, they have a trauma. What do? They go to A&E. They have an X-ray. And at A&E, their X-ray shows that they've got a proximal humeral fracture. So what will naturally happen is the orthopedic team will think, right, we've got a bone break here. We need to manage this fracture. And we need to make sure that the shoulder's not dislocated. But it might then be that because of the fact that this individual's in so much pain, they feel like they can hardly move their arm. They feel like they haven't got much strength because they've just had a fracture. And it might be that as a physiotherapist, 6 weeks later, when you come to see this patient in your physiotherapy clinic, you think, oh, they're a bit weak. Actually, I wonder if there's a cuff tear here. Would you say that that's a scenario that you might find yourself in?
Potentially. I mean, with proximal humeral fractures, they're horribly, horribly painful for 3 months. So the reality is you're probably not going... Most big proximal humeral fractures, there will be a rotator cuff tear just because of the nature of the fracture pattern. They go hand in hand. But you probably won't pick up the contribution of that until at least 3 months, because that's when patients start to do more functionally. So it's likely that it's there. How much it impacts people is varying degrees depending on the fracture pattern of the underlying original fracture. And in terms of managing that, that's a very different kettle of fish compared to what we're talking about with just acute rotator cuff tears.
Sure, no, I absolutely agree. I suppose the reason I wanted to put that on there is that if you are seeing a patient and there's a known fracture and the whole management has been, fracture, proximal humeral fracture, and as Marie said, perhaps 3 months later they still seem quite weak, just consider whether or not they might have a rotator cuff tear that may have happened at the same time as the fracture, but because the focus was on the fracture, the rotator cuff tear was missed, although, as you said, Marie...
It probably won't change the management here.
Interesting. Okay. All right, then. So why do we want to refer these people on, and what are we normally referring them on for?
So again, talking specifically about acute traumatic rotator cuff tears, so you've got your 50-year-old builder that slipped awkwardly carrying something and their arm was wrenched, and since then it's been painful and really difficult for them to move it. So again, like Khalid mentioned right at the beginning, make sure you're looking at your local pathways and protocols, because that will show you what you should do and at what time scale. So if we're suspecting an acute rotator cuff tear, so the patient has got pain, limited active range, weakness on testing, and that is likely to be painful, but you're looking more for that true weakness, and good passive range with a history of trauma, you've got to have your acute cuff tear up quite high for your differential diagnosis. Now, where I've been working, if that hadn't improved over 2 weeks, so if patients couldn't lift their arm to 90 degrees of flexion or abduction by the 2-week mark, and the suspicion was that they had a rotator cuff tear, that would warrant referral onwards. Some other places like you to give it a little bit longer and give them 6 weeks of conservative input to see whether it picks up. So you're going to need to double check your local guidelines, but essentially we want to act relatively quickly when we're thinking about acute rotator cuff tears. It's slightly different to other tendon tears, so I always find this really bizarre in that if you had someone that you thought had an Achilles tendon rupture, you'd send them to A&E. With shoulders, it's slightly different, so make sure you check your local pathways, but you're looking at within 6 weeks. If they aren't improving, or you suspect that they've got a relatively sizable tear, you're going to refer them on to orthopaedics or potentially to an interface service who may look at doing additional imaging to help with the diagnosis. In terms of what imaging we might do at the interface service, again, that's going to depend location to location and what the provision is. So we've got on here ultrasound or MRI. So again, that is up for debate. Certain services use ultrasound because it's easier to get the referrals in. Obviously, MRI is used for looking at other serious pathologies and lots of other body parts and things. So ultrasound, particularly MSK ultrasound, is now being done more and more by physiotherapists and other MSK practitioners, so that's a really useful thing. And also because the shoulder's relatively superficial, ultrasound can be used there. However, it isn't as accurate as MRI, and sometimes tears can be missed, particularly things like subscapularis tears can often be missed on ultrasound. So the MRI scans may be preferable in some places, depending on pathways and protocols, because they give a bit more information on the joint, on the tear pattern, how big it is, how atrophied it is, how retracted it is, what just helps with the surgical decision making. And in terms of what do we want to be done when we're referring on, this is a really important discussion to have with your patient. So when they're sat in front of you thinking, okay, Mr. Smith, from what you've told me and what I've seen today, I think we're probably dealing with a tear with one or more of the tendons in your shoulder. Now, typically what we do is refer you on for additional imaging to confirm that within the pathway that we have here, but we also have the option of carrying on with some rehab in the interim to see whether things improve. Broadly speaking, we can manage tears surgically or non-surgically, and sometimes it's worth having that discussion with the patient because you will have some people that really don't want surgery, and as long as they're aware of the options they've got and you can kind of talk them through the risks and the benefits, it's perfectly fine to be guided by them. In some instances, even if someone's really not keen on surgery, you can still refer them on so that they can have that discussion with someone more qualified. If that you've got the skill set to have that conversation, and I'd probably encourage most people to refer on anyway, so that decision can be made by an appropriate practitioner, unless someone is sat there going, absolutely, I do not consent to referral onwards. I'd probably still refer them on.
Fantastic, awesome. And I suppose, as you said, it therefore allows that even if the investigation is done so that the cuff tear is known about, and then, as you said, they can make a decision as to whether they want to have surgery or not from a surgeon who will perhaps guide through the risks and the benefits of those individuals. So that totally makes sense.
And that includes things like suitability for surgery from a medical perspective, but also from a tear pattern. If you've got a really massive tear, really big, in someone relatively elderly, that's going to be really difficult to repair because it's quite fatty and degenerative because it's not been a very happy tendon group for a long time, that makes surgery much more technically challenging if we're talking about a rotator cuff repair, and we might be talking about a completely different surgery such as a reverse total shoulder replacement. So that's why I always feel like there is definite benefit in referring on to people with much more specialist opinions and expertise, because then they can have those nuanced conversations with them. We can broadly talk as physiotherapists about surgery versus non-surgery, but the nuances need to come from someone with a real specialist interest.
Sure. And Josh has actually made a really excellent point, which is, would you image and refer on at the same time if you suspect an acute tear? Just thinking about current waiting times. So I
It
suppose
really
that's
depends,
a factor.
and I think obviously most physiotherapists within the UK can't access imaging. It comes from an interface advanced practice kind of role. So in most pathways, you as the physiotherapist, if you suspect an acute rotator cuff tear, probably wouldn't be able to access that imaging anyway. You'd be referring on to someone that could
Who would
access
make the decision.
that.
Yeah.
On the whole, by the time they reach an orthopaedic surgeon, they will want some kind of imaging before they make a decision about surgery. So at some point in their journey, they will have either an ultrasound or an MRI to help guide those decision making. You can diagnose a rotator cuff tear without imaging, but in terms of how things are managed, most surgeons feel more comfortable when they've got imaging that shows them a bit more information. Because like I said, it could be really, really retracted, which makes surgery a lot more technically challenging.
Sure. And I suppose the other thing, as you said, is that in most patients, we can refer on, but also continue giving them exercises in the meantime.
Absolutely. And like that's a really great option because you're not losing anything, and if they do go to see the surgeon and they jointly agree that surgery is not the right option, they haven't wasted any time. And it might be that things improve, and particularly with some of the smaller tears, so when we're talking about kind of a single tendon being involved, the body can compensate relatively well for that. So it might be that with a bit of time,
Here's what I found.
Excuse me. Yes.
with a bit of time, that can settle down, and it might be that by the time they reach the surgeon, with waiting times like Josh mentioned, that things will have picked up. So that's the benefit of continuing with rehab whilst you're waiting for them to have that discussion elsewhere.
Excellent. Yeah. Thank you so much. And yeah, as Hannah said, if you refer on, would you continue with prehab?
Absolutely, Hannah. Absolutely.
Yeah, absolutely. Okay then. So, Marie, you've mentioned this already. Some of the key assessment indicators that might tell you that your patient might have an acute rotator cuff tear. You absolutely talked about the history and whether or not that patient has had a trauma. You talked about the levels of pain they have, but you also did say that, as we can see there, resisted tests to look at the strength of those tendons and comparing your active and your passive. It may not always be that it's so textbook that active is lower and passive is okay, but naturally that's perhaps a telltale sign if your patient does present with that kind of thing. But is it also important to check the cervical spine and some of the other nerves to see whether it might be a nerve-related reason that your patient has weakness after a trauma?
Yeah, absolutely. You can get nerve palsies that can cause kind of mimicking. I've certainly seen some patients where I felt like they might have an acute rotator cuff tear, but the history wasn't quite in keeping with it, and they actually ended up having a big nerve injury. So it's always worth having a think about those differentials. But when you've got a clear history of trauma within the age group that we talked about, when they've got reduced active range of movement, normal passive, and reduced strength, you've got to treat it as if it is a cuff tear, in my opinion. And I know we've mentioned here really irritable tendinopathy. You wouldn't expect the drop off in range to the degree that you get with a true rotator cuff tear. An early frozen shoulder, typically the history won't fit with that because it won't have been a trauma, it will have just been a sudden onset.
Yeah, and that's exactly why those factors are on the page, basically, to kind of help people quickly differentiate. So yeah, with a very irritable tendinopathy, as you said, you wouldn't expect that normally there's a massive trauma involved, and we wouldn't expect that there's such a significant reduction in their range of movement. And I suppose also if they do have an irritable tendinopathy, it should be that within 7 days, perhaps even 14 days, there is a clear improvement in their symptoms.
Yeah.
And with early frozen shoulder, it might be really, really painful, and it might be that they feel like they've got less range of movement, but that's mainly because of pain rather than because, as you said, they haven't had a trauma and they haven't had a clear difference between active and passive.
Yeah.
Okay, good stuff. So I'm just seeing if there's any other majorly relevant questions that we have here. Otherwise, we'll move on. Intra mentions, should we refer a patient on who does not improve or respond to physical therapy in 2 to 3 weeks? And I think that's where you said, Marie, that
absolutely.
if you believe they've had a tear and they haven't seen much of a clear improvement in 2 weeks and you still believe that those tendons are significantly weak, then there's reason for that.
Yeah, absolutely.
Okay. Great. Let's move on to a quick word on degenerative cuff tears, I think we've put this in.
Or general cuff tears where we decided that they needed to be managed conservatively for whatever reason and they haven't gotten better. So say we've got Mr. Smith again, the 50-year-old who tripped whilst he was carrying something, and he's got just an isolated supraspinatus tear. On balance with the surgeon agreed that he didn't really want to have surgery because the risks didn't feel like they'd work out for him, and he did feel like he was getting better. So at what point would we then say, Mr. Smith, you're not improving, we've reached the end of the line with physio? So I think really important things to think about here is making sure we've explored everything and we've given it enough time, and particularly with rotator cuff tears. So say he's got a supraspinatus tear, that is not just whacking him with weighted abduction repeatedly, thinking sensibly about how we're using the rest of the rotator cuff and other compensatory muscles like deltoid and traps and things to help give him function, or looking at things like symptom improvement, symptom modification, to see what works best for him. So making sure we're not giving really painful exercises and we are adjusting things if he's not picking up, and that we're doing it for long enough. So with if we think about a slightly different patient group with massive rotator cuff tears that want to be managed conservatively, so thinking more about the anterior deltoid program, that needs to be done for at least 3 months before they start to see any improvement in most cases. So you're talking at least 3 to 6 months of conservative management before we can say we're probably not seeing inroads. And particularly with the anterior deltoid program, they need to be doing it regularly. If they have a drop off for a week, that's going to have a big impact on them. It's also worth mentioning some patient groups that potentially won't get better with conservative management. So again, if I mention the massive rotator cuff tears, the patient group that don't tend to do brilliantly, supported by research with anterior deltoids, are patients with subscap tear, because you need that kind of front and back portion of the rotator cuff to kind of give you that stabilisation of the humeral head. So if you've lost that patient group tend not to do as well with anterior deltoids, or people with really strong surgical beliefs or kind of yellow flag type things. But hopefully all of those things will have been addressed by when they saw the orthopaedic consultant or the orthopaedic specialist and came to a joint decision of doing conservative management. So yeah, bottom line is make sure you're not doing painful exercises, you adjust things as you need to, and that you do them for long enough.
Yeah, great. Now William asks a nice question, and I suppose naturally this may depend on your location and the guidelines as we've said, but William's question is, would we always offer treatment options to patient, whether it be conservative or an orthopaedic referral? Or if when the tear is manageable functionally, do you try physio for a period of time, then refer to orthopaedics?
So that wholly depends on your patient and the setup. If it was something, and again, your expertise, so I feel like I've got enough experience to be able to talk broadly about the options and the risks and benefits in my particular role about helping patients kind of guide where they want to go. If I'd thought back to when I first qualified, I absolutely wouldn't. So I probably would have referred everyone on to have that discussion at that point in time. Whereas now I feel comfortable that I've got enough basic knowledge that if I can have that conversation with them and they confidently tell me, Marie, I really don't think it's worth me going to see a surgeon, let's give this a good bash conservatively, I'll just make sure I've really clearly explained to them that if they change their mind at any point, they've got to let me know if they think things are getting worse. So ultimately it depends on your setup as well, because it might be that it's not easy for you to refer in, and also worth talking to patients about weights as well if you're feeling confident to have those kind of discussions, because if it is 6 months wait to see an orthopaedic surgeon, which is not unheard of in this particular patient group, it might be beneficial to send that referral anyway.
Absolutely. No, that makes perfectly good sense. Okay, so we're now going to move on to rotator cuff related shoulder pain, also subacromial pain and rotator cuff tendinopathies too. So I suppose if we think about the difference between this individual and the cuff tears, I suppose we're probably thinking about individuals where there hasn't been a trauma, where do you want to jump in?
Yeah, so there's been a mechanism. So they've done a particular activity, and that's been the thing that started it off, but not what we class as a trauma. So that might be an entire weekend of DIY. That might have been that they played tennis for the first time in ages, or they've done something, a new activity that they've not done for a while. So there'll be a mechanism, but there won't be a trauma. In terms of age group, this is going to be younger than what we typically see for a tear, but there is a crossover, so you're probably looking at 30 to 55, 60. They will have pain, but they should have relatively good range of movement. They might have lost a little bit in a few directions, but it should be a lot better than what we'd expect for an acute cuff tear, where they can't really move much at all, depending on where the tear pattern is.
And yeah, I suppose, so some of the stuff that we've got on here is more about if they do have rotator cuff related shoulder pain, what do we need to make sure of before we've referred them on? So as you said, kind of alluding to with the cuff tears, I've got written down here things like that you've tried to manage them within physiotherapy as much as possible. They've had a really good program. You've tried to give them exercises which are as pain-free as possible. You've worked on load management, you've worked on pain management, and despite that, they're still not going in the right direction. Is this the kind of patient that we're thinking about? Right, if anyone might be put forward for surgery, because we know that surgery isn't always successful for these individuals, it's those who we definitely are sure that physiotherapy hasn't given them the improvement they need.
Yeah, absolutely. They need to have done the right stuff for the right amount of time, and that does need to be comfortable exercises. And again, that isn't always just a loaded abduction program. You will need to think outside the box, and you'll need to try different things and find what works for the patients. Sometimes that's symptom modification, sometimes that is just a loading program, sometimes that's supine exercises, sometimes that's moving away from the shoulder completely and doing more scapular core exercises. So I think from a perspective of working in that kind of interface service and beyond, it's really disappointing when patients get referred through where they've done 6 weeks worth of rehab, and it's when you talk to the patients, it's been things like wall slides and external rotation with a band, and it was really, really painful. And you ask them about what the exercises were like, and they tell you that they didn't really do them because it hurt so much. That's really disappointing, because we know, like you alluded to, that the Seesaw trial and the FIMPACT trial show that subacromial decompression, which is the surgery we're primarily talking about with this patient group, is no better than sham surgery, is no better than watch and wait and observe them over a period of time. And obviously with surgery, there are huge risks. That very unfortunate person that reacts to the anaesthetic and dies, are they going to be happy? Are their family going to be consoled by the fact that they underwent an elective surgery when they hadn't had the right management first? And we do have a duty of care to our patients and management of resources, particularly within the NHS, making sure that we've done a thorough job. That being said, there are patients within this group who have really strong surgical or more invasive treatment beliefs. And again, if you feel like you've tried to have that conversation with them about what the management should be as per your pathways and as per what I've just highlighted in terms of at least 3 months, more than likely 6 months worth of rehab, looking at pain-free exercises and adjusting things as need be, and they really aren't buying into that, that's fair to refer on. Just make it clear when you're referring it on that they haven't really engaged with rehab, because sometimes patients just need to hear it from somebody else. Somebody, if they sit in front of the surgeon goes, I know one of the surgeons I used to work with used to say, in 3 years' time we won't do the surgery because the evidence for it is so poor. They might change their mind to go, actually, no, I do want to explore other things. So.
Yeah. No, that's great. That's really useful, and it's great to be able to speak to someone like yourself who is in working as an advanced practice physio now, who is getting these referrals through from physios. And it's really interesting to hear you say that one of the most disappointing things is, as you said, when people are referred through to see you for a consideration for should they be referred on for surgery, and they haven't really scratched the surface of physio. Yeah. So hopefully that's the main message for everyone here. If you're thinking about someone who you think maybe they've got a rotator cuff tendinopathy, maximize your physio. Make sure load management, pain management, genuine pain-free exercise as much as possible has been fully explored before you think, right, let's refer that patient on. So, in terms of why we're referring them on, I suppose, as you said, Marie, the suggestion is going to be that the surgical option is going to be a subacromial decompression.
We could always talk about injections.
Yeah,
as well.
That's on there, so go for it. What do you think?
Yeah, so if you've got someone that has done really appropriate rehab for an appropriate amount of time, but the pain's still a real factor, something that we might consider in those kind of interface or specialist roles is, are we definitely dealing with cuff tendinopathy, subacromial pain, whatever you want to call it, or is there a tear there and that's why it's not responding? So it might be that we look at doing ultrasound or MRI to help from a diagnostic perspective, or we could try something like a steroid injection, again similar to lots of other body parts. We don't like to do lots of them, and that can be used in a diagnostic perspective as well, because if patients have a good response to a landmark guided steroid injection, we know from their imaging that there isn't any tendon tears there and they've had appropriate management, it tends to be a good indicator that surgery, going in and doing some structural stuff, might be helpful for that person, but in the appropriate patient.
Sure, but as you said, the injection might be something that actually helps them with their rehab to avoid surgery too.
Absolutely, and the caveat with all injections is that it's never a standalone and that they should be doing some rehab around that. So often when they get to interface services with advanced practice physios, the injection will be done and then they'll go back to rehab and have a review in 6-8 weeks post-injection with the APP.
Yeah, and hopefully the patients will be told that the injection is not the final step. The rehab afterwards is just as crucial as having the injection itself. Jared's asked a question which I suppose looks along the lines of calcific tendinopathies. How would you differentiate clinically between which may be incidental and which may be causing the symptoms if you're considering an injection? He talks about the risks of injections, which of course is very valid. So if you have an ultrasound or an x-ray and it says there's a calcific tendinopathy, are there ways of saying, yep, the calcific tendinopathy is what's causing their symptoms, or, oh, that might just be there anyway?
I think that's a really good question. It's a difficult one and it's going to vary patient to patient, but generally speaking, acute calcific tendinopathies are horribly, horribly painful at the shoulder. So they present quite similar to acute frozen shoulder in that they come on suddenly and they're agony. So if your patient's history isn't in keeping with that, the calcium is more than likely something that's just an incidental finding. Would it change how I managed it? Probably not. So if they were presenting more like cuff tendinopathy rather than that acute, really, really painful, have we got calcium at play here that needs a barbotage, for example, I probably still would go down a steroid injection route in the first instance.
Yeah, and mainly we're talking about corticosteroid injections here, aren't we?
Yeah,
sure.
Because calcium generally reabsorbs over time. So there are surgical options for it, but most of the time they like to steer well clear.
Sure, absolutely. Great stuff. All right, so moving on to key assessment indicators. So basically, the key things that someone might look out for in their assessment to say, right, it's time for me to refer this person on. So I suppose the main thing that I've got down here is that you've gone through your normal assessment, you've gone through how painful it is, how much is their function limited, how much is their quality of life limited, and I suppose with all of those things you're thinking it is really limited and their pain levels are very high. But also, for someone like you in the service you work in as an advanced practice physio, are you really looking to dive into a review of this person's physio? What have they genuinely had? What have they done?
Absolutely. I'll be looking for signs that their symptoms are in keeping with cuff tendinopathy subjectively and objectively. And then the mainstay of decision making revolves around how much rehab they've had and how good that rehab has been. And in most instances in this patient group, they go back for more rehab rather than go forward to an orthopaedic surgeon.
Super, great to hear. You mentioned symptom modification, which is something that you could potentially use to try and see if that might be able to settle your patient's symptoms down. And again, I've just got down here, check the neck and check the nerves, because it might be that someone's been managing this patient as a rotator cuff tendinopathy and actually they've got cervical spine pathology. So always worth bearing that in mind as well, I should say. Catherine's asked, if a steroid injection was given to a younger person and continued with rehab, would would they be able to return back to competitive contact sport, and how long would it take? I suppose, Catherine, the answer is absolutely it could be that they can return back to competitive contact sport. How long it might be will absolutely vary based on individual to individual and how they respond to the injection. It is possible, as it is that physiotherapy itself could get them back.
Only thing that I'll add on to that, that's a really broad question and very patient specific in terms of what sport and how often they're playing it and things. But acutely post-steroid injection patients should have a period of rest for at least a couple of days, because steroids soften soft tissues. So if they go and do something really, really heavy, there's a potential risk of them having a tendon rupture. So just because that question's not super clear and exactly the pinpoint, not straight after a steroid injection.
Cool, very good. All right, shoulder instability. Now, I think, Marie, it might be quite useful to quickly glance over the Stanmore triangle here, which is a way of classifying different shoulder instabilities, because certain types of instability, you generally find that they might be referred on, and in some instances, there's not a reason to refer on. So would you be happy to talk us through that?
Yep, sure. So this is the Stanmore triangle, which is showing the 3 different types of shoulder instability, but it's worth mentioning that this is a continuum, so you can have contributions from different elements of the triangle, if you like. So no one's just a type 1 and that's where they sit. You can have a bit of a mixture. So type 1 shoulder instability is traumatic and structural. So these are your, for example, rugby players who went into a tackle, landed awkwardly, shoulder was dislocated. They may have some structural changes such as a Bankart, a Hill-Sachs, some glenoid labrum changes that accounts for the traumatic episode where their shoulder dislocated. Type 2 are your atraumatic group. So these tend to be your born loose, worn loose, as I think Andrew Jaggi calls it. So they are either people that are generally hypermobile, so have got that extra laxity in their tissue, so they're born loose, which means that the shoulder might be a bit more susceptible to instability, or worn loose, so acquired laxity. So if you think about things like baseball pitchers, where they get that horrible amount of external rotation when they're pitching the ball, that's an acquired laxity they've got because of their profession or their sport, and you can get that with other professions. So there are still structural changes, as in they have extra give in the tissues. That's predominantly the shoulder capsule, which can give some proprioceptive feedback to the shoulder. So there's some structural changes, but generally speaking, the history with them is, I've always been a bit extra bendy. My kneecaps pop in and out, my shoulder drops in and out, or my line of work is such that I know that I've got extra movement in this direction. So they might have a mechanism of injury that causes their shoulder to come out, such as reaching across to unplug a plug, but that wouldn't dislocate a shoulder in a non-hypermobile patient group. So that is definitely type 2, not type 1. Hopefully that makes sense for you all. And then type 3 is muscle patterning non-structural. So these are your, I can party trick, pop my shoulder out of joint patients that tend to do it in their childhood, and then it becomes habitual and becomes really difficult to do, to stop doing, They can also be people that develop really weird movement strategies, so different muscles become really hyperactive and pull the shoulder out forwards and backwards. So there isn't structural changes, there isn't necessarily that changes to the bone, the labrum, the capsule that we see with the other poles, but they have still got instability. And how we manage these is completely different. As I said, though, it is a continuum and you can get a bit of contribution of both. So I've definitely had a patient that started off as a type 1, was assaulted, shoulder was dislocated, but then because of the trauma and how scared they were, developed some muscle patterning, which was then with the bigger issue that we had to deal with first. So there is definite contributions of multiple areas here.
Super, thank you, that's really useful, and hopefully that will make these things will become important in the next few slides as we talk about referring these patients on. So Marie, you've talked about traumatic, atraumatic, structural, non-structural. Largely speaking, of course, every patient's different. You've talked about a unique situation there where you had a patient who was traumatic, structural, but then they developed some muscle patterning. where do you tend to find your patients do get referred on based on whether they are traumatic, atraumatic, structural, non-structural? What tends to be the generalised pattern for referral?
So broadly speaking, if you think about primary care physiotherapy, so either GPs referred or the patients referred themselves, you're a master of all trades, you have to see every body part, you're not a super specialist shoulder physio. So if you came across any of these patients, it'd be more than reasonable to refer them on if you felt like you'd given them a reasonable amount of rehab, because you're a non-specialist. So there are specialist centres that work on specialist upper limb units that specialise in treating the type 2s and type 3s here predominantly, because they are a challenging patient group to manage and they do need very bespoke input. So please don't beat yourselves up if you feel like you've identified someone that's a type 2 or a type 3 and you're not getting on top of it when you're seeing all the other patients and you're not a highly specialised physiotherapist in the upper limb. That's absolutely fine. Speaking specifically about your traumatics, they should have gone to A&E. If they had a traumatic shoulder dislocation, they should not be rocking up in primary care having not seen anybody else. And they should have gone to A&E, had it relocated with gas and air, and then had appropriate follow-up in fracture clinic. If you're seeing patients that are then referred from fracture clinic to see you, and you've got that history of traumatic shoulder instability in the younger, sporty or quite active patient group, and they're having ongoing instability episodes, they don't like being in the surrender position, they're finding things really difficult because it feels like it's going to slip out again, or they are having repeated instability episodes, that needs referring back. So if you're seeing someone in primary care that's had a traumatic dislocation that hasn't been seen in A&E, they probably need to go to A&E. Or they need their GP to refer them to fracture clinic so they can be managed appropriately, because in the younger patient group we might see bony changes, we might see glenoid labrum changes that may mean that they go on to have stabilisation surgery, or in the slightly older patient groups they might even have associated fractures or rotator cuff tears that become a bigger problem for them in the future. So from a safety perspective, if you're seeing someone that's telling you shoulder was out, mate popped it back in for me, haven't seen anyone else but it's been really sore since, they need to go and have that reviewed by a medical practitioner.
Sure, fantastic. And then so for your patients, we've got here about structural and non-structural, and perhaps that's why imaging is so important, to perhaps do an X-ray or perhaps an MRI to actually look to see if there are any structural changes. And you mentioned this earlier, for example, a Hill-Sachs lesion or a Bankart lesion. If you want to know more about what those things mean, we've got plenty of other webinars that go through that kind of thing. But are we kind of thinking that these individuals might be more amenable to surgery because they've got a structural issue that can effectively be operated on?
Yeah, absolutely. So again, it's the same conversation of risk management and pros and cons, and do we manage this conservatively or not? But again, that doesn't necessarily have to be a conversation that you have with the patient, but being really matter-of-fact simplistic, if there's a structural change such as a tear in the cartilage that's affecting the stability and the ability of the humeral head to stay congruent in the glenoid, repairing that cartilage will restore some, if not all, stability and potentially stop any ongoing instability problems, allow them to return back to sport, etc. Yeah. So that is more than reasonable to have that discussion about having surgery. Just going back to imaging, so when we're thinking about kind of type 2 and type 3 shoulder instability, we wouldn't necessarily image, because if they've got this kind of mechanism of injury that's really low level, not trauma, there's not going to have been enough force to cause labral changes. And imaging generally is only used to help guide kind of really subspecialist opinions, so referring on to those super specialist units to talk about kind of more experimental surgery, capsular shifts, things that aren't necessarily done in your general hospital. So thinking more about the non-structural instabilities, we tend not to do imaging there, but if they've had a trauma, we'll consider whether doing an MRI or an MRA would be useful.
Sure. And I suppose it then kind of goes on to the next question about, as you said, your type 2 and your type 3, your atraumatic, your muscle patterning. Do we actually refer these patients on? If it's as you said, there's overlap between them, but if it's someone who's purely got atraumatic instability, as you said, you're born loose, worn loose kind of individuals, do we send them on to see a surgeon? Perhaps, as you said before, is it a case whereby if you don't necessarily feel confident knowing the difference or which exact type of instability this individual has, might it be that you refer them on and then the surgeon has that conversation? But by and large, do these individuals get surgery or not always?
So your type 2s, there are some surgeries that are being done, but arguably, so they're primarily capsular shifts, but if you're thinking about the patient group where they've got that extra give in their tissues, the general thought process is although surgery might help in the short term, it will gradually return. So surgery is avoided where possible with the type 2s, and type 3s, it is completely avoided because you can stabilise their shoulder, but if you don't address the muscle patterning, they will just rip it back out again and they'll end up loads more problems because of the level of damage that they've done and all the surgical repair, etc. So from a how to manage perspective, again, have a look at your guidelines. With the type 2s and type 3s, normally in primary care, it's at least 3 to 6 months worth of conservative input before referring on to your interface service, which will help screen before referring on to either specialist centres or orthopaedic surgeons. But most orthopaedic surgeons will see a type 2 or type 3 and bounce it to a specialist rehab centre.
Yeah, because they don't want to operate on them.
No.
Absolutely. And again, perhaps, as we said a second ago, if, ladies and gentlemen, you're watching this and you think, I'm not really sure whether this is type 1 or type 2 or type 3, then please do discuss it with one of your senior colleagues so you can try and work that out, and therefore you can have that thought process of, right, perhaps they are or are not suitable to be referred on. So, moving on to why we're referring them on, as you said, Marie, we might think about imaging if they've got specific structural issues, like they've got a Bankart tear, which is a tear in the anterior inferior portion of the glenoid labrum, which is causing their instability, then that can be looked at with a Bankart repair. It might be that if they have that Hill-Sachs, which is the bony chunk that's impacted from the humerus, and that lack of humeral consistency is causing that instability, then something like a Latarjet, when they have a piece of bone inserted into that region to fix it, or a stabilization to bind all the tissues and make the capsule a lot more structured. Anything else you wanted to mention there, or does that kind of make sense?
No, that's all fine.
Okay. So therefore, some of the key assessment indicators for you in terms of who might get referred on, as you said, you're thinking about your dislocation history. How often is this patient dislocating? How is it dislocating? Is it through a trauma, or is it that they're doing that kind of party trick to kind of pop it in and out at will? And ultimately, what type of instability you think it is? And is it those kind of pieces of information that helps you decide whether or not that individual might be referred on?
Yeah, absolutely. So the dislocation history is key here. Traumatic versus atraumatic. How often is it happening? I mean, you can have your traumatics that have repeated ongoing instability episodes, so that's really important to screen for. But if you've got someone where it comes out with their arms sitting by their side and they haven't had a trauma that's the onset of that and they can relocate it themselves, or it just subluxes, you're automatically thinking more type 2, type 3. So that history will really help guide you.
Lovely. Great. And there's a question in the chat which I suppose is really, really important, which is if someone has a structural change but it doesn't give them any issues and it doesn't seem to be causing instability, would they be referred on?
Probably not. So again, this is the same kind of caveats and nuances of every body part. People can have these changes and cope really well. There are a lot of people out there with structural changes, particularly around their shoulder, particularly elite rugby players who play professional level sport, national level, international level, having not had any surgery. So you can manage these conservatively. I guess what we're trying to do with this webinar is help you to think about your thought processes with referring on. So if you've got someone with a traumatic history that hasn't gotten better with your rehab, having previously been seen and kind of screened and told go on and deal with it, you're going to be having a more discussion about, okay, we've done conservative input and you're still having problems. Do you want to go and have a conversation about what surgery may or may not be available, versus your type 2s, type 3s, you being able to identify that that's what they are and knowing that there isn't really going to be any surgery that they're going to do, but if you referred on, they could go to a specialist unit. But Yeah, absolutely. You can absolutely manage traumatic instability conservatively in the right patient.
Wonderful. Fantastic. Now, a quick, really important note. Marie's mentioned it a second ago. If you have your patient who kind of walks into your clinic saying, oh, I think I dislocated it, or yes, I did dislocate it, but my mate just put it back in and I haven't done anything about it since, the answer is go to A&E. You're going to send that patient immediately to A&E so that, as Marie said, they will be addressed, they'll be x-rayed, and they'll be managed appropriately and referred to fracture clinics. So really, really important that you do that. Okay, I can see that we've got other questions in the chat. I think I'm going to move things on because we want to get through everything, but we will come back to questions later if we have time. So we're going to go on to the lower limb. So knee injuries, this is what I've been lucky enough to work a lot with in the past, and naturally we get a lot of questions here on Clinical Physio about referring patients on who potentially have had a knee injury, so it's a pleasure to be able to talk you through some of this. So first of all, what kind of pathologies are we looking out for? We might be thinking about ligament injuries, ACL, MCL, LCL, PCL, meniscal injuries, posterior lateral corner injury. So that's the as you can imagine, the posterior and lateral corner of the knee, which can also be affected by twisting injuries. Osteochondral defect, this is a little bit of a pothole-like situation I commonly describe it as, where sometimes, particularly with the patella, for example, you can have a trauma where someone falls directly on their patella and a little bit of a chunk of cartilage of the retropatella breaks off and it creates a little pothole that means that when they're moving their patella up and down, it gets affected. Or you might be thinking about something major like a fracture or a tendon rupture. So those might be some of the things that you're considering when you're assessing your patient who's had a real acute knee injury and they come into your clinic and they're really, really struggling. So some of the key things that I would think about when the patients would come to see me in A&E. Have they had an acute injury, and how significant was that injury? Was it they had a clear trauma where they were on the sports pitch and they twisted and they felt a real sudden pain in their knee which swelled up immediately, versus someone who said, yeah, I was just sitting in my chair, I stood up and then it was really painful? Because as you can imagine with the latter, there isn't a huge amount of force going through their joint. There probably isn't a huge amount of force that can significantly tear a ligament or tear their meniscus or cause a tendon rupture, whereas you can imagine that the real big clear traumas might do. We talk about, with these acute injuries, sudden swelling. So patients who have their trauma and suddenly their knee has ballooned. Now, I've put the question there, do you know why? And the reason being is that I remember talking to an A&E consultant who I had seen the patient and they had a lot of swelling, and the consultant said, oh, what did you do with them? And I said, well, they didn't fit the picture of an ACL injury. They didn't fit the picture of a large meniscal tear or a posterior lateral corner injury or something like that. So, so I've referred them on to see physio. And the consultant said, so why do you think they had swelling? I said, I'm not sure. And then the consultant says, well, in that case, we better image them because we need to know why they have that swelling. And ultimately, when someone has that sudden, really acute swelling, it could be a missed fracture. It could be that they have really high clotting problems, and therefore it might be that they bleed more easily, and therefore it's really important that you assess them and image them in that respect. So that's something that I've always remembered. So do you know why they've got that sudden swelling? And if not, do you need to investigate it appropriately? So locking and giving way. We talk about these a lot of the times in terms of special questions for the knee. So when we talk about locking, we talk about mainly the inability to extend the knee at end of range. And classically, this is thought to be an issue that comes about when someone has a true meniscal tear. Now, not all meniscal tears will lock, but if you have true locking, then it's certainly increases your suspicion of a meniscal tear. Giving way. So with thinking about our individuals who, not they are walking along the road and then suddenly they have a sudden pain at their knee. We're thinking about patients who turn, twist, change direction, and suddenly their knee buckles and collapses on them. And it's really important that if your patient says that their knee does give way, ask them about it. Tell me about the giving way. What happened? So you can try and work out, is this true giving way? Or is this just the patient's definition of giving way that doesn't necessarily paint a ligament injury picture? What about the ability to straight leg raise? Now, this is a top tip that I heard from an orthopedic knee consultant, which is that if your patient has had a major trauma to the knee and they can't perform a straight leg raise, it could mean that they have a fracture of their patella, a quadriceps tendon rupture, or a patella tendon rupture, because we need all three of those structures to be intact for the quadriceps mechanism to be able to lever the knee in order to produce a straight leg raise. So that's always a really good test just to do to identify whether they may have had one of those injuries. Inability to weight bear. So naturally, if your patient has come to see you perhaps 7 days after their injury and they're really struggling to weight bear, that might make you think more suspiciously about a serious injury compared to your individual who was unable to weight bear for a day and now suddenly they're able to walk, or they've been able to get some improvement in their weight bearing with crutches. Special tests. Now you might be thinking about things like your Lachman's test or your anterior draw test for the ACL, your valgus test for the MCL, varus for the LCL, all the other tests that we know about at the knee. But what about if you have an individual who their knee is so painful and so sore that you feel you can't do your special tests? Well, that's where the knowledge of the subjective history signs really comes in handy. I was lucky enough to work with a knee surgeon where he could trust me that if I had a patient who walked in, who had a twisting injury, non-contact on the sports pitch, who reported really sudden swelling, inability to play on, and had giving way since then, the surgeon would be happy for me to refer them on to see him, knowing that there was a high chance that that patient had an ACL injury, even if I wasn't able to do their tests because their knee was so sore and painful. So bear that in mind, that you can tell a lot from the subjective history, and if you think there's enough information there to warrant referring on and you can convey that to the surgeon, then go for it. And then I just put a little scenario there which I saw once in my practice, which is a patient who didn't have a trauma but who presented to A&E with really sudden, really significant, really acute swelling. And if we go back to the question above, do you know why they have sudden swelling? This person didn't have a trauma, but there was real concern about them. And having septic arthritis.